All right, I'd like to welcome everybody. We have a special guest today, Dr. Christopher Hall from Mercy, OBGYN. He's going to go over OBGYN emergencies here for us, back to the ambulance. He's got a great lecture for us today, and he's going to go over things that's more interactive, so opportunity for us to ask questions, be with him, just discuss things like that. So if you have any questions, concerns, none of that, just holler out and be informed. With no further ado, Dr. Christopher Hall.
Hey guys, Chris Hall. Nice to meet everybody. You want your phone?
No, it's going to have to run the sound through it.
Oh, okay, cool. Okay. If at any point you guys can't hear me, then just stop or interrupt me. I was never really good at doing formal lectures, so I'm just going to do this more informal, if you will. First off, is there any burning questions about y'all had a recent experience or whatever, and y'all weren't really sure what to do, or y'all have a question about what y'all could have done differently or anything like that?
I think we haven't had a birthing experience until this year.
That's good.
So
December. So that's good. So, there's a lot of stuff that you can cover. I know that there's, you're kind of telling me that, especially, and this is sort of my experience too, that there are, I think, a lot of folks in and around Bella Vista who do elect to try and deliver at home, or they do it with a doula or a midwife, which most times that goes fine, but sometimes that can go very wrong. Other times you can have women who go into preterm labor, they don't necessarily know they're pregnant, or they're really early and they didn't know that they were in labor. So there's always something that can happen, and you don't really know sort of what to expect. A couple of things to sort of talk about, because I think, you were saying there are some specific situations where you guys, y'all, especially if y'all don't deliver a lot of babies, which I'm sure y'all don't, even though y'all probably aren't going to encounter this very often, it's good to know kind of what to do. Just looking through some of these protocols that you guys have, I think they're actually really well drawn up. As far as, so just kind of looking at, there's the complications of childbirth, just the second page. There are things like preterm birth, multiple pregnancies. Fortunately, twins, triplets, those sorts of things are not going to be very common. But unfortunately, with multiples, you're more likely to have preterm labor and preterm delivery. The things that you can really, change in sort of on the scene is if you arrive and y'all are told that someone's delivering and you walk in and the baby's head is out, what do you do at that point? First, the best thing that you guys can do is just take a deep breath and try to get the patient to calm down. They're in labor, they're feeling, especially once that head is out, there's so much pressure that they feel to go ahead and push as hard as they can to get the shoulders out and the body out. So sometimes that means just looking the mom in the eye and being like, listen to me, listen to what I'm telling you, let's focus and do this. Especially if the head is out, or even if she's crowning at that point, you're not going to be able to get her to the hospital before she delivers. So it's probably better for you guys to deliver on scene. One of the first things to do, there are a lot of different delivery strategies as far as positioning. Probably the easiest way to have the mom focus and have a controlled situation is for her to be on her back. So if she's in hands and knees or something like that, I would have her roll over. If the baby's head is already delivered, I would try to support that as best you can, just so it's not flopping around. And then one of the things to do is actually to reach up. The easiest way to do this is to reach up kind of more the anterior side of things, just behind the pubic bone, and feel this area of the baby's neck. If you feel a nuchal cord, this will happen about 15-20% of the time that they have a nuchal. usually it's very loose. So you can just reduce it, just pull it, you know, even if it's a little tight, go ahead. A lot of times it'll stretch. Just try to take your time. If you can't get it to reduce, okay, if you can't get it to pull over the baby's head, I know I was looking in this, it actually says to basically to clamp and cut the cord before delivering the baby. I would actually encourage you guys to try and have the baby's anterior shoulder deliver first, okay? Because if somehow you cut that cord and then you end up in a dystocia, that's a really, really dicey situation. Because not only do you have a kid that's stuck, but now you have cut off any blood supply that it might be getting with the umbilical cord. I mean, if there's a shoulder dystocia, you know, functionally speaking, that kid is going to be hypoxic anyway. But if you're cutting the cord, like, that's sort of the end game, and, you know, he or she's not going to be able to breathe. The way that you do that, the way that you deliver the anterior shoulder, it should be very easy. Just do gentle downward traction on the head. Don't pull out, but just gentle downward traction towards the tailbone or the bottom of the bed. It's going to be a lot easier. I sort of forgot to mention this. It's going to be a lot easier for you guys to actually deliver the baby if the mom is sitting on the edge of the bed. If they're way up on the bed, then you're not going to have that room. Your hand's going to run into the mattress. Or you know, if they're in the bathtub. Obviously, if they're in the bathtub or on the floor, you know, unfortunately, you just got to make do with what you got. The other thing to, you know, again, with shoulder dystocias, this isn't something that, again, you see very commonly. The one thing I did notice on your algorithm, it's actually really well drawn up. But the second thing that it says for you guys to do, where it says to have the mom pull her legs back, the medical term for that is McRoberts position, okay, where you actually hyperflex the legs at the hips. I would do that first. Do that first because a lot of times just doing that will actually change the angle enough to where the shoulder dystocia will resolve, okay? If you do that and then actually if one of you other guys, you know, because y'all are teams, right? Y'all are never like alone, right? What you can do while you have the mom do McRoberts position, actually have your partner give suprapubic pressure. So it's not fundal pressure. You're not pushing at the top of the uterus, but you're actually just pushing right at the top, just above the pubic symphysis. Okay. If it's the right shoulder, okay, you actually want to push to the mom's right. Okay. If it's the left shoulder, then you want to push to the mom's left because you're basically trying to push the shoulder around. Okay. A lot of times that in itself will resolve your shoulder dystocia, and then you can go ahead and do your other motions. Certainly you could try these other maneuvers as well. Don't worry about the medical terms, but basically if you kind of guide your hand in, if you try McRoberts position and the suprapubic pressure and that doesn't resolve, you can slide your hand in over the back. Usually, especially for us guys, you're just going to be able to get like one or two fingers, not your whole hand, and just push right behind, you feel the scapula and just push right behind the shoulder. And a lot of times that's enough to kind of reposition things to get that. The other thing that you can do is actually reach posterior, okay, and actually try to get the baby's right or the posterior shoulder out. A lot of times, unfortunately, those kids' arms are extended. So the best way to do is actually to get, if you run your hand down their humerus, put it in their popliteal fossa and just gently get it to flex. You can get it to flex and then pull the hand up over their face. And once you get the posterior shoulder out, you'll have no trouble getting the anterior shoulder delivered. The biggest thing, and we have to remind ourselves, even in the hospital, when we do this, I don't say we do it all the time. I mean, I've seen, a couple of shoulder dysocias in the last 6 months. It's not very common, but the biggest thing to do is just take a deep breath. It happens to even the most experienced people. You get in there and you're like, well, this is not an ideal situation. This kid's not coming out. And then your adrenaline kicks in even more, and you just want to sit there and pull and pull and pull. Last thing you want to do is actually just sit there and pull on the head, because that's where it's stretching the baby's brachial plexus, and that's how they can get the nerve palsies. If there is a shoulder dystocia where y'all go through all those maneuvers, y'all try everything again, and you can't get it to resolve, and you can't get the baby delivered. Y'all have bandage scissors. I know y'all probably do, right?
Oh, yeah.
Scissors.
Yeah.
Okay. What y'all can do is actually get some scissors and cut the baby's clavicle, and then it'll come out. It's not ideal.
Yeah.
But at that point, if you've gone through all your maneuvers, you're essentially talking about a baby who neurologically may or may not be intact, and you've got to get that kid. If it's the difference between having an Erb's or Duchenne palsy and having a neurologically intact kid, I think everyone in this room would say, yes, I would rather my kid have, issues with moving their arm than having other central nervous system issues. It's sort of a no-win situation, but you're picking the less of the severe things.
We have to reach out to med control before. I think I'm going to do it.
I'm not. Yeah.
Call the ER doc.
Right.
Hey, this is where we're at.
I certainly, like, y'all don't, I've never had to do that. It's one of those things where you read about it in your, the OB textbooks, and you read about it in the literature, sort of like a Zevanelli procedure where you actually push the head back in and you do a C-section. That's like if it's been like 10 minutes and nothing's happening. Certainly at that point, I mean, hopefully, I've never actually had to cut a clavicle, so I don't expect that y'all would ever run into that. But that's sort of like, you're in the field. That's sort of the last resort effort. And if, as long as you don't cut too deep, you're not going to get into the nerves or the artery underneath that. The other, back to, it's not actually on y'all's, or I didn't see it. It's not on y'all's list, but I've had a case recently where a patient was delivering at home, and she was brought in by some other local EMTs, and she actually had a uterine inversion. Okay, this is where and this wasn't something that EMTs did, but basically what happens is when you're trying to deliver the placenta, sometimes people can get a little bit too aggressive with pulling on it, okay? And you can basically pull it inside out. It's basically like trying to, it's like if you have your sock turned inside out, you basically reach inside, grab the toe in your sock, and you pull it that way. Functionally, what happens is the uterus contracts down on itself, and it can't contract in such a way to actually be hemostatic. And so they have a postpartum hemorrhage, but then you can't get it to stop. You give them urotonics, and that doesn't stop. If that happens, if you guys are in a situation where you're walking the door and the baby's born, the umbilical cord's somehow been cut, and the placenta is sitting there at the introitus, okay, and it's not releasing, okay, I would feel up on their belly and see if you feel the uterus, okay. Normally it should just feel like this big hard lump, okay, for lack of a really fancy explanation. If you guys feel a divot, okay, it almost feels like two smaller stones, and there's going to be a big divot right there, I would not remove the uterus. Okay, I would leave it there. Okay, I would bring her straight to the hospital, and I would not remove it. If somehow that has been removed, and then you have this big, mushy, meaty mass looking at you, okay, one of the things y'all can do, y'all have terbutaline?
Yeah.
Y'all don't? Y'all have albuterol, right?
Yeah.
Nebulizers. So y'all can actually give them albuterol through a nebulizer, and you could also give them nitroglycerin. Okay, that helps the uterus relax, so that by the time you guys get to the ER or whatever hospital, the ER physician or myself can come down there and actually reduce it. It takes a little bit of time to work because it's one of those things where the uterus sort of acts like a tourniquet on itself. So blood flow to the uterus it's not gonna happen like within a couple seconds. But by the time that you guys get to the ER or the hospital, hopefully we're able to get it pushed back in. Okay. That may be something that you'll see once in your career, if ever. But it's something that if you see it, it's very evident that that's what's happening, and you'll know immediately.
How much nitro does it take to get?
Usually, I just give one dose sublingually. And I would do between that and the albuterol, just a single nebulizer treatment, or if y'all have the MDIs or whatever you guys have, that would
do like 10 milligrams, 2.5 for a while.
Okay.
Put like 4 of them in there.
Okay.
And give them like 10 milligrams.
Yeah.
Constant.
Yeah. It's whatever you guys normally do is helpful. Yeah. Yeah.
Potassium, like 10 to 20 milligrams.
No, they just need some sort of, in that situation, it's one of those situations where uterotonics actually makes the situation worse. Okay, so giving her Pitocin or Cytotec, if y'all had it or anything like that, is going to make it worse. Because the uterus contracts down on itself so that it can't, but it's turned inside out, so it sits there and the placental bed site just continues to bleed. Okay. This is like a recorded safe.
Yeah.
So the lady that I saw her approximately 20 minutes after she delivered, and she had lost 5 liters.
Oh, wow.
So, because typically blood flow to the uterus for a normal single pregnancy, blood flow to the uterus is about 800 milliliters per minute. So they can bleed quite a lot in a very short period of time. The other thing, have any of you guys ever seen the prolapse cord? Again, probably this is not something that you guys are ever going to see. By definition, essentially, the patient's water has to have broken. Okay. And what's happening, assuming that the baby is head down, but a lot of times it's more common if the baby is breech, just because you don't have sort of that head that's basically occluding the opening, if you will. Basically, it's where the Eliquis cord gets down below the head or the presenting part. That is a situation where I would, assuming that they're going to be in labor, again, I would definitely agree, get them in knee chest position or get them in some sort of recumbent where they're flat. I would give them, based off what you guys have, assuming that they're in labor, I would give them nitro or albuterol, something, again, to get the uterus to relax, because this is an acute event. I mean, if this happens in labor and delivery, then we roll them straight to the operating room and do an emergency C-section, because it's functionally cutting off. It's basically like cutting the umbilical cord while the kid is still in utero. So I would do that, and unfortunately, somebody has to basically elevate the presenting part of the baby. I know this says a sterile glove. At that point, it doesn't really matter to me whether it's a sterile glove or a nitrile glove that you pull out of your pocket. If we're talking about, brain cells for the kiddo, we can give them all antibiotics. But the biggest thing is to get the head elevated out of the pelvis. And if your hand's not hurting, you're not pushing hard enough. And basically you elevate it for as long as you can until you get to the hospital and she gets a C-section. So, I don't think that we really need to go through like talking about multiple, delivering twins. I don't think that there's anything that I would say is different. I would be shocked if you guys ever had to deliver a breech fetus. Usually those take a lot longer to deliver. So, if you guys get called to, a house and there's a breech, I would encourage her not to push, and I would get her to the hospital as soon as possible. Because delivering a breech, I would argue that delivering a breech fetus, regardless of their history, whether it's their first kid or their eighth kid, delivering a breech kiddo is much more technically difficult than even doing a shoulder dystocia. The risk of head entrapment is incredibly high, and unless you have forceps or some sort of training in delivering the head, it's going to be a very dangerous situation. So,
that's most like mom trying to have the home with a midwife or doula.
Yeah.
And then
the biggest thing with a breech delivery. So I read through where was it? I read through everything, and this is actually a very good breakdown of how to deliver it. Have them on push. You don't want to pull on the kiddo until really it's out to the shoulders. Okay. The easiest way to actually support the torso is to get a towel. I don't know if you have blue towels or some sort of support, and basically just wrap it under the belly and have your assistant or the doula or the husband or whoever hold the kiddo up. Pull a loop of the umbilical cord down to make sure that it's not, because what will happen is it'll most likely get pinched at the insertion site where it goes into the belly. In this situation, once you get to the point to where you see the clavicles, okay, on the back, what you can do is, if you place your thumbs basically over their SI joints, you basically sort of can rotate them back and forth to get to the point to where you can pull their arms down, okay. And then at that point, the thing that is tricky about delivering the head is that sometimes the kid will want to extend their head, okay, which makes it a lot bigger of a diameter. Even a fully dilated cervix can get caught on this chin, and it becomes very, very difficult. The medical term for delivering the oncoming head is called a Morso maneuver. Basically what you do is you slide your hand. I'm right-handed, so I would use my right hand, slide it under the baby's belly, the chest, up to the neck, and you basically put your fingers on their maxillary prominences and pull it down. And then you have them on push, and you basically deliver it that way. So that's why it's important to have someone supporting the torso. Okay, your forearm is going to support it partially, but it'll be a lot easier for you to concentrate on what's going on with the kiddo's head if that torso is being supported. So, the other thing, as far as, you guys may actually see this more often just in general and it's not necessarily eclampsia or preeclampsia, but seizure activity. Okay, because seizures are, whether it's epilepsy or pseudo seizures or whatever, those are fairly not uncommon in women that are childbearing age. Obviously, if there's a family member or someone that knows their history and tells you that yes, like they have epilepsy and they forgot to take their Keppra for the last couple of days, that would make me much less suspicious of them having preeclampsia. I think I like how you guys, check the blood sugar. It's always not a bad idea to give them, I don't care if they're diabetic, you can give them G50. But IV access is going to be important. And then what I would actually argue is to get some vital signs. So obviously if the patient is seizing, do the things that y'all are trying to do from like a BLS, ALS standpoint, turn them on their side, get their vitals. The patient is probably going to be hypertensive regardless of whether they have eclampsia or epilepsy. But I would argue that unless a patient's family member or significant other is telling you that they have epilepsy, I would give them magsulfan. Because if you give someone who has eclampsia a benzodiazepine, they're more likely to vomit and aspirate than to actually, for them, unless they're in status epilepticus, which is actually pretty rare for someone who's eclamptic. Mag sulfate is going to be a much safer thing for you to give in the field. Okay. What dose of vials do y'all have?
We have the 1 gram.
1 gram. Okay. So generally, if I am giving a patient intramuscular magnesium, then I give them a shot of 5 milligrams in their right hip, and I give them a shot of 5 milligrams in their left hip.
Okay.
If y'all are able to get an IV and give them IV mag, then I would give them a 4 gram mag bolus.
IV push.
So you can do an IV push. The way that
like in a 100 bag, our protocol reads over 5 to 15 minutes.
Yeah. So the way that we do it on labor and delivery is that we give it over 30 minutes. And I think it's just because the volume that we give them, I think it's a 250 mil bag in the hospital. I could be mistaken. And I think it's more of an issue of just not giving them a huge fluid bolus if they're preeclamptic, because then that could give them like pulmonary edema. But you said 100. Y'all have 100 milligram bags. That would probably be fine. I mean, you could give it to them over 5 to 10 minutes.
4 grams on 150.
Yeah. Yep. But that's what I would do. And if you give them the magnesium and, hopefully by the time that y'all are able to finish the magnesium, hopefully y'all are, getting close to the hospital. Obviously, if they are still seizing at that point, then I would probably, look at giving them a benzodiazepine. What do y'all typically use? What do y'all have? Versed. Okay. At that point, that's when I would probably give her Versed. But I think that even if it's a seizure due to epilepsy, I think it's probably not. They're probably not going to enter status epilepticus, and we were always taught that it's a safer option, especially in the field, especially if you don't know a history, to give them magnesium and then try to figure out their history, then to give them, Ativan or Versed or something like that, and then possibly aspirate if they've eaten. So, what questions do you guys have? I know that's a lot of random stuff to talk about.
Even if they that have history seizures and miss their tripper for a while. Taking a seizure, you'd still probably go ahead and.
I would still, unless you have someone telling you at the scene that they have epilepsy and that they're giving you that history, I would give them MAG. If you have that history, then I think it's safe to give them Versed. But of course, at least in my experience, things typically happen where you guys get called and there's no one there that really knows their history very well. They're with a friend who knows that they take some sort of medicine, but they're not sure what it is. And, it's usually an epileptic seizure, only lasts for a couple minutes anyway. So I think it's a safer option. I think if you ask a lot of obstetricians, they would agree. So, the other thing just to think about, I know you guys don't really have uterotonics, but if you guys get called to a house where there's been a home delivery, the baby's out, placenta's out, and she is bleeding, okay, I know y'all don't have uterotonics, but assuming that, you rub on her belly and it feels like this big, just mush, you don't feel like there's a uterine inversion, one of the best things that you can do is actually just continuously rub on her abdomen until you get her to the hospital.
So we did create TSA. I know that schools have a lot of studies back years.
Yeah, you could do that, and that's it's probably not going to hurt. Studies have shown pretty consistently that it's not, unless you are giving them continuous doses over 24, 48 hours, it's not going to, increase their risk of getting, venous thromboembolism. Excuse me. So y'all could definitely do that. Y'all have, 1,000 milligrams? Yeah. Okay. Y'all could definitely do that. Common things being common, most cases of postpartum hemorrhage are a result of uterine adeny. And so actually massaging the uterus. I certainly don't expect you guys to know how to do a bimanual exam. And certainly if they're at home, they're not going to have an epidural, and they are more likely to kick you in the face than anything else. So just doing a uterine massage just above the umbilicus, and they're not going to like it, but it may save their life. So it's a simple but a lot of times very effective measure. So yeah.
You're giving the nitro since they're probably already bleeding at that point, and you're still concerned about.
So if you just show up, so I know I mentioned nitroglycerin earlier. I would only do that and albuterol if you had a uterine inversion or if you had a cord prolapse. If you had a situation where you come in, baby's out, placenta's delivered, and you rub on their belly, and the thing with a uterine inversion is not usually going to be brisk bleeding. Okay, what I mean by that is it is shooting out. Okay, I mean I've had postpartum hemorrhages due to uterine adeny where it's literally coming out so fast it's running up their leg and hitting the floor at the base of the bed because it's got so much velocity on it. So if it's something like that, then I would definitely not give them nitroglycerin. I would just do a uterine massage, rub on their belly just above the pubic bone, and I would definitely get IV access, obviously. Right. You'll typically just do like one AC IV, right? Okay. Yeah, I was gonna say if they're bleeding that bad, it would be probably a good idea to put in two.
Try get forms so it'll strictly with bending.
Yeah.
Try different forms or looking for. If we're not successful, you won't have that.
Okay. Y'all have an IO gun? I guess that makes sense since y'all are.
Yeah, we can't do centralized.
Gotcha.
It's closer to the back.
Yeah. Yeah.
Yeah.
How often do y'all do that? I'm curious. How often do y'all have to do that?
Oh, I just ordered the third box in the last 2 months now, so.
Okay.
Every card.
Okay. I just I've seen it used on OB patient a couple times. I haven't actually seen it up here. It was in training. The other thing, and I see this a lot, and I'm sure y'all see it a lot, where you guys are called to an accident and there's a pregnant patient. Certainly if it's any woman who is involved in an NVA who's pregnant needs to be evaluated. I don't necessarily think that they need to be brought in by you guys, unless it's like a high-speed accident and, they have other, head or neck, injuries. But if you guys are transporting, and this goes for really anything, transporting a pregnant woman, it from the standpoint of making sure that the fetus is oxygenated, it's actually a good idea for you guys if y'all can actually put her in a little bit of a left tilt. The easiest way to do that is just to get, a blanket, roll it up, and put it under the mattress or under their right hip, and they don't have to be on their left side, but just kind of tilting them. That way. Yeah, it's a simple but effective measure. We do that for all of our C-sections. Because there's a period of time where we've quit monitoring and we're waiting for the surgical prep to dry and that sort of stuff. We do that a lot of times just for laboring patients in general. So, because it basically gets the uterus up off of the aorta and the vena cava, and make sure that you can maximize blood flow to the uterus. So,
what about the NVA where the mother's dead? We don't really have a way unless you can see the baby moving there.
Yeah.
Whatever.
Yeah. Fortunately, I've never had to come across that situation. At that point, you sort of have to use your clinical judgment, I think, and there's not going to be a right or wrong answer. If it's something where you basically coded the patient right there at the scene, doing chest compressions, and you had a pulse when you first got there, I would just beeline it to the hospital. It's unlikely that the kid would survive, but I have seen cases where the mother was in cardiac arrest, and we did a perimortem C-section, and the kid actually came out with AVGARs of 8 and 9. Part of it depends on, what the situation is, how acute the cardiac arrest was.
So if the mother there's no chance that even with cardiac arrest algorithm that we run would help. We need to worry with pushing epi, that we just need to do chest compression. Like if we have what we think is a viable baby.
Right.
Could we just maybe like more head trauma.
Just
Just them over with smash.
Chest compression, but we still need to follow our algorithm of pushing epi.
So I would do your ALS, I would do your ALS protocol, but again, chest compressions are probably going to be the best thing to make sure that blood is getting circulated.
I was just thinking of more lines of I'm doing this to try to keep blood flow to the baby.
Yeah.
So
if you have
pushing epi
if you have a situation where the mom, and you guys have done all your stuff, and essentially the mom is probably gone. Okay, chest compressions are going to be the biggest thing, because that's, the thing with arterial flow to the uterus, it's all based off your map. And unfortunately, chest compressions is probably going to be the only thing. You can do epi, that's probably not going to hurt, but chest compressions would be what my focus would be. So. Mm-hmm. No, and if anything, I don't want to say that it would help. Epinephrine is metabolized by the placenta to some degree. Part of it depends on how far along. Generally a older fetus the placenta is going to metabolize a little bit quicker. We don't really know why that is, but it probably is not going to hurt. I would not be worried about it causing like an abruption or something like that. I would be more worried about the MVA doing it. But I mean, when the kid gets delivered, if he comes out and FR is 1, he's going to get epi anyway. So as part of just like the code protocol for neonatal resuscitation. So, what else? Do any of you guys off the other stations have questions?
Any questions from 2, 3, 4?
No. No? Okay.
Okay. All right. Well, thank you guys for letting me come in and talk and meet you guys. Like I said, I'm one of the OBGYNs down at Mercy. I've been here for about 1.5 years now. So y'all, hopefully we don't have to come across each other's paths in any of these situations, but hopefully this will help you guys feel a little bit more comfortable if y'all do get called to one of these situations and have to do this.
Thank you so much.
Yeah, you bet.